And we should shift to the next session. And the chairperson for the next session is Dr. Gaurav Chawla, Dr. Rohit Gupta, Dr. Mukesh Kalla, and I will request Dr. Vikas Singla to continue because Manoj Sahu has some urgent work and because of that he was not able to come. So I request Dr. Vikas, Dr. Gaurav Chawla, Dr. Rohit Gupta and Dr. Mukesh Kalla to proceed with the session and request speaker to stay on the time as we are absolutely on the time in the first session. We should continue and maintain the
Thank you,
same
Dr. Puri.
timing.
Thank you, everybody.
Thank you.
Hello, Dr. Singla.
Yeah. Hi, Dr. Gaurav. Now we are starting with the next session. The first talk is on anatomico-pathological staging with the EUS, when it matters the most. And the speaker is Dr. Sudipta Dhar Chaudhary. Sudipta is from, we all know it's from CMC Vellore. He is an excellent endoscopist and very knowledgeable, and he have the answer for all the difficult questions I know. So over to Dr. Sudipta.
Thank you, Vikas. Thank you for a very kind introduction.
Hello.
Yeah. Hello. Yeah. So at the very outset, let me take this opportunity to thank Dr. Puri for giving me this opportunity. So today we are discussing on the staging of cancers. And as you know, the staging of cancers, it gives us a standardized measure of the extent of disease. It helps us guide therapy and prognosis of an individual. The most widely accepted staging system that we have is the TNM classification, and we have a number of modalities at our hand to establish this. This includes CT scans, MRIs, PET, and of course EUS. Now, for today's discussion, I'll just focus myself on those 4 cancers, basically the esophageal cancer, the stomach cancer, pancreatic cancer, and the rectal cancers. Esophageal cancers are staged, the T staging of esophageal cancers range from T1 to T4. And the T1 cancers are those which involve the submucosa. T2, as you can see, involves the muscularis propria. T3 extends beyond the muscularis propria. And T4 involves adjacent structures. Now, the advantage that EUS has over other imaging modalities is that we can very clearly visualize the gut wall layers very clearly. And this is one major advantage with endoscopic ultrasound as compared to CT scan or any other imaging technology. And this has been exploited to use and get the T staging of esophageal cancers. Now, just to highlight this is one patient with this sort of a lesion on the esophagus. When we put in the NBI, we could see that there was a type 5 IPCL pattern with an area formation. Now, the question is this patient amenable for an endoscopic submucosal dissection? When you look at the EUS, what you can see very clearly that the lesion extends only up to the submucosa. The muscularis propria is relatively free of the lesion. And you can go ahead and perform an endoscopic submucosal dissection here. This is a slightly larger lesion. On the NBI, you can see there's a loss of vascularity. The question here was that what was the T stage? Is it a T2 lesion or a T3 lesion? And here you can see that the lesion has extended beyond the muscularis propria up to the adventitia, indicating that it's a T3 lesion. This helps the surgeon plan surgery, whether to give an upfront chemoradiotherapy or proceed directly with surgery. The other aspect, of course, of staging is a detection of regional lymph nodes. Now, esophageal cancers, as we all know, can metastasize to the paratracheal nodes, to the paraesophageal nodes, or to the abdominal nodes. And the staging of nodal staging is dependent on the number of regional lymph node metastases that we can identify. EUS, because of its close proximity to the gut wall, enables us to visualize these lymph nodes. But how do we say that the node itself is a benign or a neoplastic one? Now, this is a criteria which came in very long back, almost in 1994, so 2 decades now. And and we have been following this criteria. It depended on increasing importance, order of importance would be if the node is hypoechoic, if there's a sharply demarcated border, contours are around it, and the size of more than 10 millimeters. Now, there is, of course, a high inter-observer variability in this aspect as to what we call as a hypoechoic. Some person may call it heteroechoic. And the other aspect, which is much more difficult to determine, is whether the borders are actually fuzzy or very sharp. So therefore, in 2019, a new set of criteria was developed, and this criteria involved looking at the shape of the gland, whether it's a round or an oval gland, and looking at the size of the gland, that is the long axis diameter more than 20 millimeters and the short axis of 10 millimeters. And with this, the area under curve was 0.82. So this had a very high sensitivity and specificity for picking up a neoplastic node. So at the end of the day, what is the utility of endoscopic ultrasound for preoperative staging? Now, this is a meta-analysis of 44 studies, and which shows the overall accuracy for T staging is around 79%, for nodal staging is 71%. But it's the highest for T1 lesions, that is 77%, and T4 lesions for 84%. When you have to substage between a T1A lesion and a T1B lesion, then it's very, very sensitive, 84 and 83%. But there are caveats to use of EUS in esophageal cancers, especially when you're trying to discriminate between a T1A and a T1B lesions. Most of the centers have what is a traditional EUS scope, which has got an imaging frequency between 7.5 to 12 megahertz. And therefore, it may not be practically possible to discern a T1A and a T1B lesion with those scopes. What we have to use probably is a mini probe here. The other problem with EUS is that when you come across this sort of a lesion, where there is a luminal obstruction, and if you cannot pass the scope beyond a lesion, then obviously the accuracy of EUS comes down. One of the options tried very long back was to dilate those strictures and then pass the EUS scope. But the problem was that there's a very high risk of perforation, and for a diagnostic procedure, that risk of perforation is virtually unacceptable. Now, coming to gastric cancers are again staged almost similar to that of esophageal cancers, the submucosal and mucosal. Again here, the advantage of EUS is a very good visualization of the gut walls. And with EUS, you can very clearly see the different layers of the stomach wall. Just to highlight this thing, this is a very recent case. This was in November when a patient with this sort of a lesion was referred to us. Biopsy showed gastric cancer. The questions from the surgeon was, is it a T2 lesion or a T3 lesion? Because CT is not able to discern this. Here you can see there is a sort of a papillary architecture, some ulcerations. When you put in the EUS scope, you can see that the lesion has extended beyond the muscularis propria into the serosa, indicating it's a T3 lesion. Again, helps the surgeon plan therapy. And a Cochrane meta-analysis has shown that if to discern between T1, T2 versus T3, T4, the sensitivity of EUS is 86%. Between T1 and T2, the sensitivity is 85%. And between T1A and T1B, there are very little number of studies there, only 20 studies. Again, the sensitivity is 87%. But here again, the problem is you have to use a very high frequency probe. Even for nodal staging, the sensitivity is 83%. So how does EUS compare to multi-director CTs for the preoperative staging of gastric cancer? This is a meta-analysis of eight studies, including 1,736 patients, of which 3 of the studies used mini probe. For T1 staging, the sensitivity is very good, 82%. Whereas for multi-director CT, the EUS is only 41%. Even for nodal staging, EUS scores over MDCT. What about pancreatic adenocarcinoma? And this is one cancer probably most of us who practice EUS would be getting the maximum referrals for. And I'm not getting into the details of this, but if you look at the T staging of pancreatic cancer, the T staging is virtually based on size. T 2 to less than 2 centimeters, 2 to 4 centimeters, more than 4 centimeters, or involvement of the celiac artery or the supramesenteric artery. Now, at EUS, you can also very clearly see a lesion. You can identify adjoining lymph nodes. And if scanned properly, this is one patient who was a borderline resectable lesion, planned for neoadjuvant chemotherapy, referred for an EUS and FNAC. But at FNAC, you can see that there is a space-occupying lesion in the liver, which was not picked up on the standard CT scan, thus making it an unresectable disease. So there is an upstaging that happens with EUS also. Just to highlight this further, this is one of the cases. This is a patient with a 36-year-old gentleman with a chronic alcoholic, came to us with significant pain abdomen for 6 months. This is the CT scan. You can see a very large dilated duct and this lesion there in the head of the pancreas. Now for him, what happened was that he had an EUS done earlier and FNAC showed only atypical structures and possibilities were inflammatory and neoplastic. Now, we all understand that when we have an alcoholic patient who comes with this sort of a mass, undifferential is definitely an inflammatory lesion. And, uh, and to operate on an inflammatory lesion may be a bit too much, but therefore we need to sometimes establish the diagnosis. So at US, you can see there's a very nice, well-defined lesion, which was definitely hard when we used the elastography. Even at when we use the contrast to demonstrate whether it's an inflammatory in neoplastic lesion, you can see this lesion is not taking up any contrast studies, indicating it's a very hypervascular structure. And USFNAC in this gentleman showed adenocarcinoma. So imaging modalities which are available for pancreatic adenocarcinoma range from MRI, CT scan, EUS, and PET-CT. Overall, the sensitivities of all of them are virtually similar. And the specificities of all of them are same, except for PET-CT, which is much lower at 70%. So you get a very good accuracy, whether you use an MRI, CT scan, or EUS. But what happens when you have smaller lesions? You have smaller lesions. This is a meta-analysis of 4 studies of 206 patients. 70% of the lesions were of 2 centimeters. And they were all labeled as indeterminate on multi-detector CTs. Here again, the sensitivity of EUS is very high, of 85%, showing that in very early lesions, which are actually amenable for surgical resection, EUS has a definite role here. But beyond diagnosis of cancer, the more important point of pancreatic adenocarcinoma is resectability of cancer. And the resectability of cancers depend on one factor which is very important, is to degree of encasement of vessels. Where is it involving less than 180 degrees or more than 180 degrees? And this is, I think, one of the most important determinants to determine whether the lesion is a borderline resectable or an advanced lesion. So can EUS identify pancreatic cancer venous invasion? Just to highlight this, if you see a tumor thrombus within the portal vein, more likely you're dealing with an advanced venous invasion. If they are collaterals, this is also a sign that they are venous invasion. The other, which is a much more subtle and very important sign, is that abnormal vessel contour with loss of vessel parenchymal sonographic interface, which indicates that there is a loss of interface and involvement of the vessel. And if you can identify the first jejunal branch of the superior mesenteric vein, then that's it. That also helps you to determine resectability. The other aspect is, of course, pancreatic cancer involvement of the arteries. Here again, you can see this is a body lesion, where you can see that it's involving the celiac artery. So how do you determine an arterial invasion? The arterial invasion is slightly more different from a venous invasion. There are 2 studies from here, both from Japan, show that there are 3 criteria which really demonstrate that there is an arterial invasion. 1, if there is a vessel contour irregularity. Number 2, if there's a clear invasion, or there's a loss of hyperechoic vessel wall. And in fact, if you use the other 2 criteria, that is contact without loss of hyperechoic vessel wall or no invasion, then most of the tumors which are more than 1000 micrometers away from main vessels can be correctly identified at EUS. There is an incremental benefit of identifying unresectable lesions when you do a EUS. Now, this study, 8 retrospective studies included patients who were identified as resectable at CT and MRI. And when the EUS was done, there was an incremental benefit of 23% when we looked at conventional CT. But in today's times, most of it is multi-detector CTs. I'm not going into much details of this. Now, going back to tissue acquisition is probably required when there's imaging is not consistent with cancer, or when there's a resectable disease. But if there is an atypical mass at imaging, borderline resectable, neoadjuvant therapy, and palliative care, then we need to obtain a tissue. So in pancreatic cancer, the role of EUS stems at those 3 areas only. When there's a mass of stricture and a low suspicion for a malignancy, we do an EUS to determine the type of lesion. If there is a borderline resectable, before neoadjuvant chemotherapy, we do EUS, and therefore in a non-resectable case, before chemotherapy, EUS is required. What about rectal cancers? Well, the rectal cancers, again, the T staging of rectal cancers is here, which you can see that is involving the submucosa, muscularis propria, T3 going into the mesorectal fascia, T4 extending beyond the mesorectal fascia. Now, at EUS, you can clearly determine the levels of the gut wall: mucosa, muscularis mucosa, submucosa, muscularis propria, and adventitia. The other imaging modality, which is a competitive modality, I would say is a very good modality, is high resolution T2-weighted MRI. And even in this, you can very clearly discern the submucosa, mucosa, and inner muscular layer. So how do you choose? This is again one of our cases where there's a sessile lesion in the gut. When you did an EUS, you can see this is not extending beyond the musculus propria. Now, how good is EUS in differentiating various T stages of cancer? This is a meta-analysis which was quoted very often by Puli et al. Which showed that when you use EUS, there's a very good sensitivity for discerning all these levels of cancer, T1 to T4. And the pool sensitivity and specificity to the range of 80 to 95%. But then this became a question because in the clinical practice, many of us don't come up across this. And therefore, this was a quality assurance study from Germany. We showed 384 patients. And there was a very poor concordance between ultrasound and pathological staging of the cancers. And EUS tended to understage or overstage the cancers. Most of the lesions now we identify on MRI, and MRI can give a very good spatial correlation. The other problem with EUS is that it cannot give the circumferential resection margins, which is a very important factor to determine resectability. Therefore, at EUS, the disadvantage of rectal is that it is invasive, cannot identify extramural venous invasion and circumferential resection margin. Therefore, MRI scores above EUS in rectal cancers. So therefore, to summarize, I would say EUS has a definite role in a role of early cancers in the esophagus and detecting regional lymph node metastasis. In stomach, again, early cancers and regional lymph node metastasis. Pancreas, very limited role to identify resectability, but useful in indeterminate lesion. In rectum, it has a very limited role. Thank you so much for your patient hearing.
Thank you, Dr. Sudipta, for
Thank you, Sudipta.
Hi, Gaurav.
Can I ask a very basic question? In the C esophagus, we have three modalities. We have image enhanced endoscopy, we have CT scan, and we have EUS. CT is very accurate, I think, for the T3 and T4 lesions, and NBI is very accurate for the T1 lesions. Is there any real role of EUS left in the C esophagus as of now?
I think currently we hardly do any staging on the with EUS as it's concerned for C esophagus. In very early stage lesions, when you're talking of T1 lesions, the question sometimes arises on the NBI that we are not, especially when you see a type 5 IPCL pattern or something, you're not exactly sure whether there is involvement of the musculus propria. It's in that small select subset that maybe EUS has some role. Beyond it, I don't think so EUS has much role in the staging of esophageal cancers.
Same thing for stomach cancer also, Sudipta.
Same thing. Same thing. It's only if you have an early lesion. Again, at certain lesions, you might, because the idea is that if you have a mini probe, you can discern it. But most of us use a standard scanning scope, and therefore to discern a T1A and a T1B lesion becomes very difficult. It might as well do an endoscopic submucosal dissection, send it for histopathology, and then determine the level of whether there's a lymphovascular invasion or not.
Sudipta, Rohit.
Hi, sir. How are you, sir?
What about antral lesions, submucosal lesions? Because the water is not there, so you don't get a contrast. How easy or difficult is it to see the level where it's invading? Or you do need a probe?
For the antral lesions, I actually do the patient in a supine position where I find that the water stays a bit longer in the antrum compared to other positions. That's one thing. Again, as you said, sir, it's sometimes very difficult. You cannot push the scope there. Water does not stay there, and you cannot get a good acoustic clumping along with the balloon itself. So with a standard scope, some very small lesions, I find it extremely difficult to do it. And quite a few of the referrals are actually this to see what these lesions are for. So,
yes. So do you use a probe, mini probe? Or?
I don't have a mini probe, sir.
Okay. So one more question. Do you still use EUS for after downstaging?
No, sir.
No. And do you do an FNAC of all lymph nodes when you have a concomitant lesion, or just send him for surgery?
If there are concomitant lesions, if they're typically characteristic of a neoplastic lesions, we do not do FNACs of all lesions. We definitely do for one if it is there. But if there are more than one or three, then we don't do it. We just label them as possible neoplastic and send them for surgeries.
So sorry for interruption. Any question from Dr. Kalla, so we can shift to the next speaker just to maintain the on-time conference.
Yeah. Sudipta, that was quite comprehensive presentation.
Thank
How
you.
good is use of elastography when you need to differentiate between CHOP versus chronic pancreatitis?
It's sometimes very difficult, sir. I use it very occasionally when you have a very well-defined lesion and you can get an adjoining normal pancreatic parenchyma. In the setting of a chronic pancreatitis, I have not used elastography to determine the stiffness of the pancreatic tissue. And we are using the Olympus scope, which really does not have a clearly defined parameters to call it at which point the strain ratios become significant.
Yeah, and last question, Sudipto, this new technology which is creeping in, RCI, I think by Fusion, does it help anyhow in early malignancies in esophagus?
I have no clue about that, sir.
All right.
Sudipto, one question from the audience, I think panelist has not seen. How you will differentiate a malignancy versus inflammatory? Can EUS has some criteria? You can say any lesion, either it is malignant or inflammatory, either in the pancreas or in the esophagus or in the stomach or in the rectum. There is any broad specific methods? You have a 30 seconds, Dr. Sudipto, so we can maintain the continuity, please.
So I'm just talking, I think the question primarily relates to the pancreatic lesions where at some point we cannot discern whether that the lesion is either a neoplastic or a thing. What we use here is a combination of sorts, standard imaging, looking at the duct, whether the duct is going through it, whether the duct is getting cut off by the lesion. That's one thing on the standard imaging at EUS. Using elastography, you may sometimes be able to see whether it's a very stiff tissue. The other thing, of course, to use is contrast. And with contrast, if you see a very hypovascular structure, more likely you're dealing with a neoplastic lesion rather than a inflammatory one.
Thank you, Sudipto, and I wish you should continue. And the chairperson can invite the next speaker, please.
The next speaker, I think, is Dr. Vikram Bhatia, and he'll be speaking on EUS in hepatology, anatomy, pressures, and beyond. And I think Dr. Vikram Bhatia needs no introduction. He's a renowned endosonologist all over India and all over the world. Over to you, Dr. Vikram Bhatia.
Thank you, Dr. Gaurav, for the kind invitation. Can you see my slides, please?
Yes, sir. We can see your slides.
You can see my slides? Okay. I'll begin by thanking Dr. Rajesh for giving me this very important topic, EUS in hepatology. For most of the topics that I will cover, there is no firm consensus on how we go about doing things and how we define things. So at least some, if not most of what I speak here will be my personal opinion, and the audience and the panelists can choose to differ. So just to share my views on this, so I'll be covering on the EUS anatomy and nomenclature of the liver varices collaterals. EUS as a
the slideshow, please. So the screen will be bigger. Slideshow, if you can do it.
Sorry.
So slides are visible, but in slideshow, it is not in slideshow mode.
Sorry. Can you see?
Or presenter mode. Or presenter mode. Is okay. Yeah.
Okay. So also EUS guided varicose endotherapy, because that is part of hepatology. EUS guided liver biopsy, and something about EUS guided therapeutics directed to the liver. So I'll start by the anatomy and nomenclature of liver varices and collaterals. And before I do that, we just to highlight two publications which we made. First was the linear EUS anatomy, where we described the liver segmentation, liver anatomy, and also the vascular anatomy at the liver hilum with my Japanese colleagues. This was published in Digestive Endoscopy in 2013 as How I Do It section. Then subsequently, we have published a radial EUS imaging of the liver in the endoscopic ultrasound more recently in 2019. And here we highlight the unique ways in which the radial EUS probe can be used to image the liver. I shall not go into the details of this, as all these papers and videos are in the public domain. So this is how we visualize the esophageal varices. The esophageal varices are located in the lamina propria and the submucosa of the esophagus.
Slides
are not moving. Slides are not moving.
I'm sorry, just allow me.
Yeah. Now it's okay.
Sharing seems to be paused. I'm so sorry. Just a minute, please. Okay, I think my slide should be moving now.
Yeah,
Yes,
now,
sir. Now it's okay, sir. Now it's perfect.
Okay, I'm sorry, my mistake. So the varices in general at any part of the GI segment are classified as periesophageal and paraesophageal collaterals, but practically I don't think that makes a difference. Periesophageal being what touches the muscularis mucosa, paraesophageal which does not touch the muscularis mucosa. But this sort of again repeated definition of paraesophageal collaterals does not make any sense. The perforators are channels which cross the muscularis propria of the GI lumen, and those are the perforators which are often used for directed therapy. Now, when we come to the stomach, please remember that the greater curve is defined by the spleen. And so if you have the spleen in section, either on the radial US scope or on the linear US scope, you are in the territory of drainage of the short gastric vein and the posterior gastric vein. And the varices which you see in this section are either GOV2 or IGV1, which are what you do EUS guided endotherapy. The left gastric vein is located along the lesser curve of the stomach, which is the area between the left lobe of the liver and the gastric wall. So you can often see dilated left gastric vein between the stomach and the left gastric wall, and you can trace it into its subsequent divisions, and obviously you can find the collaterals. In general, I find it extremely difficult to define the perforators in a gastric varix. Now, this is a landmark article. I call it a landmark article by Dr. Bhiman when he was working in SGPGI. This is way back in GIE 1999, where he defined the rectal varices as more than 3 millimeters. He defined the normal rectal wall as being less than 3.5 millimeters. He defined pararectal collaterals, and he defined congestive rectopathy. And the definitions given in this paper still stand true. And I think all endosonographers should read this as the basis of their studies on rectal varices. Now, we define rectal varices as more than 3 millimeters linear or serpiginous structures in the rectal wall, perforators as a color-directed flow, which is red, which is towards the transducer, and a spectral Doppler waveform, which is above the baseline, which indicates that the flow is towards the probe, and a exit perforator as the reverse, usually color-coded as blue, which means that the flow is going away from the probe, and a spectral Doppler, which is below the baseline. The EUS is also very useful in defining portal biliopathy, though not strictly part of hepatology, but we are pretty aggressive in doing intraductal sonography, and this is one of our publication where we do IDUS to define the choledochal collaterals, the indentation, the strictures, stones. Usually there are a multiplicity of pathologies in this condition, and this is how you can see a large paracholedochal collateral sort of and garlanding the choledochus. This is usually the PSPDV, which angulates and indents the mid bile duct. Then what about the paraesophageal collaterals? These are all very old studies where large paraesophageal collaterals were defined if these collaterals were larger than the splenic vein in that patient, or if they were more than 5 millimeters. Now, why should I be interested if the patient has large paraesophageal collaterals? Because patients who are prior variceal bleeders have larger collaterals. And if you have larger paraesophageal collaterals, then over the next 6 months to 12 months, there is a higher likelihood that varices are going to recur and the patient is going to rebleed. This data is present for both EST as well as EVL. And more recently, this is a paper from Sao Paulo, Brazil, who reiterated the same findings that, look, if you eradicate your esophageal varices by EVL, then if the paraesophageal collaterals are more than 4 millimeters in diameter, there is a high chance that the varices will then recur. Gaurav, are my slides moving?
Yeah.
Yes, sir.
Okay.
Yes, sir.
Okay, so again, a very interesting paper. I don't have the time to dwell into it, but this is a Japanese paper by Kuramochi where they trace the left gastric vein, and if you remember your anatomy, it divides into two, anterior and posterior branch. If the anterior branch is larger or dominant, these patients have more varices, more bleed, while the paraesophageal, the posterior branch feeds into the collateral, and these patients sort of bleed less. Now, moving on to the assessment of portal hemodynamics. These are again very old studies, and I wish some of us would take this up again. The azygous vein is sort of a mirror or a reflection of the blood flow through the gastric and the esophageal varices. And we know that in cirrhotic patients, the flow in azygous is significantly increased more than 4 to 6 times. If you are using a linear probe, you see that the azygos is dilated. You cannot compress it with the probe, and that is sort of a early sign or a thumbnail that this is a portal hypertensive patient. But we can actually calculate the azygos blood flow by pi r square. We can measure the diameter of the azygos vein and also the blood velocity by spectral Doppler. And these are very old studies, 2001, one from Nishida, one from Copenhagen, Denmark. And they showed they used endoscopic ultrasound for measurement of azygos blood flow and also portal blood flow, and called this as non-invasive hemodynamics. And they showed that if you give these patients beta blocker, if you give these patients terlipressin, the flow in the azygos decreases, and they quantified this flow even without a change in the vessel diameter. And they actually compared it with invasive thermodilution methods and showed that measuring azygos blood flow and portal blood flow is actually accurate. Subsequently, these papers have not been taken up by other investigators, and further progress has not been made. So these are left at that. Then we have become more aggressive. These are pig studies by the William Brook group and Samuel Gide group, who showed that you could, well, puncture the portal vein, measure pressure. These authors left a catheter in situ and measured pressure for up to 30 minutes and showed that the pressure measurement was accurate, comparable to a transhepatic portal vein pressure, and this was also safe. One very aggressive human study by Kenneth Chang and Huang as the first author. This is a human study in 28 patients, some having portal hypertension, some not. They did a 25G needle puncture into the intrahepatic portal vein, into the extrahepatic portal vein, and second puncture into the hepatic vein, and measured the difference between two and showed that, well, this correlated, they could measure the portal pressure gradient. They did not have a HVPG as a reference, but they showed that portal pressure, one, could be measured by a small handheld instrument, and two, it was, well, safe. So feasible and safe. Clinical utility, well, Dr. Chang advocates this a lot, that he does a biopsy, he does portal pressure measurements before and after treatment, particularly in fatty liver patients. But my take here is that there are certain unanswered questions. So from a clinical point of view, there is a correlation of variceal recurrence or rebleed with, well, paraluminal collateral size. But is it actually better than the standard liver function parameters, indirect tests of liver fibrosis like FibroScan and HVPG? What is more promising to me is that can portal hemodynamic parameters measured by US probe replace or substitute invasive HVPG measurements? And then, well, all of these studies I've shown you had used a radial probe. Is linear probe as good or as better than a radial probe? Now, rushing over the variceal endotherapy, again, many unanswered questions. There are a lot of variation in described technique. This is the kind of table that we set up. Question is which varices? Esophageal perforators have been targeted, but most of us don't need to do it. Gastric varices are a target. Again, there is a lot of variation whether you go and find perforators or you target the intraluminal varices. Ectopic varices is where this technique is exceptionally useful, mainly duodenal varices. Also, I'm particularly very fond of using this in rectal varices. Again, some controversy in which is the injectate. People have used glue alone, coils followed by glue and thrombin. But currently, most patients use either glue alone or they use, coil followed by glue. The injection route for gastric varices, transcrural versus transluminal. With a forward viewing scope, the transcrural was used, but transluminal is the route that most of us use now. We go into the gastric fundus, rotate over to the spleen, fill with water and inject into the varices themselves rather than the perforator, and also the patient selection. Dr. Rajesh, my time has gone very fast. I was given 20 minutes. Can I go on for 2-3 more minutes?
Yeah, Vikram, please go ahead.
Because I was given a time of 20 minutes, I'll finish in 3-4 more minutes.
Yeah,
rush through.
Vikram, no problem.
So these are just to show you the intravascular coils that we use. Most are by the Cook company. The one is Emrai, which is a 035 coil made of Inconel, and the other is a Nestor coil. Personally, I like the micro Nestor embolization coil, which is 018 diameter, and this easily passes through. And this is a platinum coil. And the importance of these wool or nylon fibers is that they form a scaffolding for the glue, which is subsequently injected, and therefore the risk of embolization is supposed to be less. And usually 1 or 2 coils are enough to cause a scaffolding for the intravascular coils. What about the needles? Personally, again, my personal preference, what you need is a flexible needle. A 19G needle will take both 0.018 and 0.035 coils. And this is the kind of needle that I use. If you use a 22G needle, only 0.018 coil can pass. But what is very important is that you avoid a side port in the needle, otherwise your coil will get stuck. This is just to show you a video. I prime my FNA needle with distilled water because I use undiluted glue, and then I'm afraid my normal saline can thrombose in the long needle. The delivery catheter is lower locked. The coil is pushed into the needle, and then I use the stylus of the needle itself, sometimes a stiff zebra wire, to push out the coil. Now, this method is applicable to all varices that we use. What is very important is the selection of gastric varices for EUS endotherapy. Now, if you use EUS endotherapy in such kind of varices, you will obviously make a couple of injections, but the patient does not benefit. A endoscopic selection is a prerequisite. We inject only GOV2 or IGV1 like this, and these are the varices which are amenable to EUS guided endotherapy. I shall skip over this, and this was showing us a duodenal varix with massive bleed, how we inject coil and glue. I also use the mini probe very extensively because mini probe guided evaluation and treatment. You can pass a mini probe through a standard 2.8 millimeter channel scope. It helps me distinguish the folds from varices and the patency of varices. And then once you have the varix focus, you can just remove the mini probe and make a guided injection, pass a mini probe again and confirm that the varix is obliterated. So this is another way of EUS guided endotherapy which you can use. Now, last section, and I shall again rush through it. Sorry, Dr. Rajesh.
Vikram, please take your time.
Okay,
because you are a very good speaker. I want you to take your time, please.
No, I'm sorry. I thought I had 20 minutes. But
Please.
Okay. So anyway, this is the last section about EUS guided liver biopsy. This is an important part of EUS hepatology. So which patients have been studied with EUS liver biopsy? Now, there are many studies, and for ease of understanding and for this talk in this forum, I have compiled these studies so that we can understand. I have excluded TrueCut biopsy studies. So these are all the studies from 2012 to the latest study. Please see that most of the EUS guided liver biopsy studies have included patients who had abnormal LFT, mostly fatty liver disease on imaging, and they have excluded patients with coagulopathy. So most studies have excluded patients with INR more than 1.5 or platelets if they are less than 50,000. Most studies have also excluded patients with cirrhosis, except the NITO study, where they neither excluded patients with cirrhosis nor they did any lab cutoff. So most of our experience is with non-cirrhotic patients with fatty liver or transaminitis with normal coagulation. So there is minimal data on cirrhotic patients. And please remember that the EUS guided liver biopsy has not been studied in decompensated cirrhosis, whether it is safe over a transjugular liver biopsy. These are the procedural details of EUS liver biopsy that I have attempted to tabulate. Again, these are all the studies. Note that everybody except the last study has used a 19G needle. So first message is that you use a 19G needle for EUS guided liver biopsy. Again, most of these studies have used either a Procore or an Expect or a fork tip or an acquire needle. So both a large bore hollow aspiration needle as well as cutting FNB needles have been used. There is a variation in suction. Some have used wet suction, some have used full suction, but most studies have used suction to acquire a liver biopsy. Most patients have used a fanning technique, anywhere 7 to 10 motions. And in general, the gist of these studies is that you use a 19G needle with suction, you make multiple to and fro movements in the liver, and you make 1 to 3 passes, usually in the left lobe. Sometimes you can take the right lobe from the duodenal bulb. Now, what is an adequate liver biopsy? This is a very important topic. The ASLD defines that adequate liver biopsy is more than 20 millimeter in length. The Royal College British guidelines more than 25 millimeters. EASL and APASL say that a liver biopsy is adequate if it is more than 15 millimeter in size, and a complete portal tract more than 11 or 10 is what is called a adequate liver biopsy. Are EUS liver biopsy specimens adequate? In general, all the studies have shown that if you take EUS liver biopsies, they fit the standards given by the international societies. So see the aggregate liver length of the biopsy specimens obtained by EUS, 36, 14, 30, 20, 30 millimeters, and adequate number of complete portal tracts. This is just to show you the Jose Nieto study, who included cirrhosis, that a very large number of patients, they could acquire more than 15 complete portal tracts. In another large proportion, they could get 11 to 15 complete portal tract. And in cirrhotic patients, this is the kind of liver biopsy these operators got with a sharp cork or a fork tip biopsy needle. Also, there are studies which show, and there are 2 subsequent studies after this. So there are 3 total studies which have compared a US guided liver biopsy retrospectively with percutaneous liver biopsy and with transjugular liver biopsy. And all 3 studies, this is one, but there are 2 more, have shown that the length of the liver biopsy, the complete portal tracts are better or equivalent to a percutaneous liver biopsy or a transjugular liver biopsy. So all of these studies show that, well, EUS guided liver biopsy is not only effective, it is equivalent or superior to the other modes of liver biopsy, but this is an evolving feature. Last question, how about the complications and safety? If you look at percutaneous liver biopsy, it is not innocuous. There was one very good study by Minook in Gastroenterology 1987, who monitored the patients with ultrasound after they underwent a liver biopsy, and they said that 23% had hematomas. Most were asymptomatic. These are the complications reported by the EUS FNB studies. Again, most common is pain, and pain happens actually in a very large proportion. In this study, they found that, well, with FNB needle, almost 1/3 patients had pain, and the pain could be very severe. However, almost everyone settled with analgesics, and there was only one hematoma in this study. This is one of my own patients, just as a caution. And look at the large liver hematoma. Even though if I was very, very cautious, this is my patient, no problem. Next day, the patient presented with a hepatic laceration and hematoma in the left lobe after a US guided biopsy. So one should not go home with the message that US liver biopsy is very innocuous. One should stick to the standards that I have shown and not be very adventurous, still be very careful. One slide on US guided therapeutics. This is a very old study on US guided IPSS or a TIPS like stent placed with Zilver, showed it was feasible in pigs, subsequently has not been reproduced. People have been very adventurous for liver abscess drainage, aspiration. However, one must understand that when you do a EUS guided entry into the liver, it is an unsterile track, unlike a percutaneous entry where you prep or prepare the skin. The organ of entry is non-adherent. The stomach and the liver are non-adherent. So it is not simply that you enter a liver abscess cavity and place a pigtail, you will end up into problem. A percutaneous tract may be safer. There may be some role in caudate lesion. In HCC, although there are papers by P. Singh et al., there is no advantage over conventional imaging. I do a lot of cirrhotic patients, but I find HCC detection and diagnosis and FNAC extremely difficult for me to distinguish, at least with my cognitive ability. I find that detecting a HCC in a cirrhotic liver in practice is exceptionally difficult. So this is again a underutilized area. So to summarize, EUS has a selective role in evaluation of esophageal, gastric, and rectal varices. I find EUS to be useful to clarify doubtful gastric varices, large gastric folds, confirm obturation of gastric folds. We can obviously define a lot of anatomy and collateral circulation, but then what to do with this information is still uncertain. What I find promising is that EUS may have an alternative role to HVPG for portal hemodynamic studies. EUS guided therapeutics, variceal obliteration, portosystemic shunts, vascular intervention, promising, but as of now, the status should be still taken as experimental. EUS liver biopsy can provide adequate samples in the majority. 19G FNB needle should be taken as standard, and the standard contraindications of coagulopathy and significant ascites remains and limited experience in cirrhotic patients. So thank you, Dr. Puri. Thank you, dear chairpersons. I have tried to summarize the entire hepatology and where US stands.
Thank you, Vikram. I request chairperson, because we are 5 minutes delay, and we can ask Vikram one-to-one question on telephone if there is any queries. Everybody knows him, and we can ask other speaker to come. Sorry, Vikram, we are 5 minutes late.
No, thank you.
Minutes.
Thank you.
Can we invite the next person, please? Dr. Julio, chairperson, will invite.
Yes, the speaker for the next is Advanced Diagnostic Techniques with EUS, when, what, and where. Dr. Julia Ziglias Gracia will be speaking on next. Dr. Julia.
Okay. Yes, I'm here. Can you hear me?
Yes, sir. Again, able to hear you.
Okay, so I hope you can see the slides. I think you're not yet looking at the slides. I think now it's go. So first of all, I will like to thank the organization for this kind invitation for me to be here with you in this AUS Summit 2020. Thanks, Dr. Puri, for the invitation and for the organization and also for the chairmen of this session. Unfortunately, we cannot meet together. I would love to be there with you in India, but because of the conditions that we have today, it's quite complex. And I would like also to think about the topic of my today, because as advanced diagnostic techniques associated to AUS, it's been my field of work over the last close to 20 years that I've been starting to do AUS. So we're getting to the point, and when we talk about advanced diagnostic AUS, I was asked about 3 questions that I want to summarize in 2. One is what, and the other ones are when and where. And if I'm just trying to think on what, I think I'm thinking about the types of methods related to AUS that is going to be really an advance in the diagnostic capabilities. That means what do we have from the technical point of view that might increase our diagnostic capabilities. And when we talk about when and where, probably we can summarize in what are the indications or situations in which we can really use these methods of advanced diagnostic AUS. So what is really advanced diagnostic techniques associated to AUS? I think we can summarize in 3. I think we all agree that making a biopsy, AUS guided, is really a diagnostic part from AUS, not in the very beginning, in which biopsy was considered even a therapeutic AUS, not anymore. But I think there's going to be some specific roundtables during this very nice meeting that would focus on AUS guided tissue acquisition. So I'm not going to speak anything about this. And I realized that advanced diagnostic methods is elastography and contrast enhancement for sure. And that's, I think, what we are all thinking about. And just to let you know, these are 2 main very good diagnostic techniques associated to AUS that have been really increased their use over the last years, because with these methods, we can evaluate the stiffness of the tissue. And we've learned, and I will show you some images from the past, that stiffness is related to the potential malignancy or malignant behavior of the lesions that we're evaluating, but also some more. And when we talk about contrast enhancement, we're speaking about the evaluation of the vascularization of whatever is an organ or whatever is a tumor. So this is what is really advanced imaging. And I think this is the topic of advanced diagnostic techniques associated to AUS. So just to briefly summarize what is elastography. Elastography, I think you all know that is an imaging modality evaluating the relative stiffness of the tissue within the body and its response to the compression. Importantly, and this is a very important tip and trick when you think on elastography, it is not like with the percutaneous one that you need to really push with the probe to the abdomen or to the thyroid gland or whatever. And most of the times we just make a slight compression with the tip of the probe, but mainly we are obtaining this compression from the big vessels that we have in the abdomen, mainly from the aorta, probably, which is the main, and that's why we have this curve that you see when you place the software of the elastography. We've learned from the past that hard has a blue pattern, soft is red, and intermediate is green. And what we've learned from many studies, that I will summarize the data, but this is a very important slide and this important message. You make an elastography, you see, and we've just made most of the studies on the pancreas, but at the end, the pattern is very similar to the rest of the organs. But believe me, you see green homogeneous pattern, that's usually the normal appearance of the pancreas. When you see this, all the pattern here with a little bit more heterogeneous and small blue spots or even red areas, this is very much related to inflammation. When we turn this the opposite, so we have mainly blue with some green spots in the middle, that is mainly related to malignancy and mostly related to pancreatic cancer. And in the other hand, when we see a very, very homogeneous blue, very well-defined lesion, this is mainly related mostly to neuroendocrine tumors, but to malignant neuroendocrine tumors. But it's not only the patterns, it's also that we can semi-quantify the stiffness. So we have two options today. Maybe we have three, but I'm not going to detail into the third one because there is not enough studies. One is that we can perform the strain radio, but we also can perform the strain histogram. And now we have some very, very recent data on the shear wave elastography, but I can tell you that it's not really improving what we can obtain with the standard strain radio and strain histogram. So this is elastography. The other advanced imaging is contrast enhancement. And we know that we can really, with this method, better align lesions, evaluate microvascular evaluation. We can assess also for therapeutic procedures. And if we come to the pancreas, that's probably the holy grail of these techniques. If we see a hypovascular lesion, this is mainly related to pancreatic cancer. If you see an hypervascular, this is mostly neuroendocrine tumors, but also some metastases. And when you see an isovascular, this is mainly related to an inflammatory process in the pancreas. And we will discuss a little bit on how we can see with these techniques some other indications. So this is what is really the two main techniques that we have available today as an advanced diagnostic techniques. And the next point is, let's check what are the real clinical applications. What is the background, the literature, and what is the knowledge to use these techniques today? So this is the list, but I will go more in detail on all of them. So we all know that Elasto is very useful in solid pancreatic lesions. I cannot agree that Elasto is not useful in chronic pancreatitis. It is. The only fact is that you need to learn. Here I have some examples from my unit, but also from the European group that we study involved in Elasto studies. Look, this is the typical pattern when you see a pancreatic cancer. Is a heterogeneous blue lesion in the pancreas. You do two different cases here. This is how we usually see, for instance, an inflammatory process, heterogeneous green pattern. Look, this is a very homogeneous lesion, green, so it is a little bit strange to see a green lesion that appears to be an neuroendocrine tumor that we should think in a blue one, but this is because this is a G1 benign neuroendocrine tumor, so it's not so hard as the malignant ones. And this is because of the density of cells inside of the lesion. And this is probably the key point to understand what is the problem with chronic pancreatitis. The problem is that chronic pancreatitis usually has calcifications. Nothing is harder than calcium. So how are we going to see calcium? Blue, but that's logical. It's not meaning malignancy. It's just meaning that calcium is hard, and that's why it's blue. So whenever you're facing Elasto in a chronic pancreatitis, please don't try to skip from your mind and from your view calcifications, and try to focalize in those areas with no calcifications in the surroundings of the tissue. And in this case, particular case that I have in this slide, okay, here, you can see there is no calcifications, small blue spot in a chronic calcific pancreatitis, and we just direct the biopsy there, and that was a small foci of adenocarcinoma in the setting of a chronic pancreatitis. And the most important part of Elasto is to learn and understand what you are seeing. And for that, you need to understand what is the technique about and what is the background of the modality. If we go into the literature, and I've just tried to summarize in this table all the results from many years of studies, just go to the final yellow part. I think that Elasto is very sensitive to detect malignancy, but the study has not shown a very good specificity. And that's the main problem of chronic pancreatitis, and the problem of trying that we need to increase our learning skills in this specific part. But among all, I think Elasto is very useful to differentiate benign from malignant solid pancreatic lesions. But this is a very recent data. It is not only useful to differentiate between different types of lesions, but it's shown also to be useful for staging, for vascular staging. And you can see in this study that has been recently published last year, that we can increase our sensitivity, specificity, negative and positive predictive value, and accuracy in difficult stations, vascular stations, increasing the accuracy of dynamic CT scan and standard beam mode. So please, if we have elasto, we can also use it. And it's very nice how we can see the elasto blue pattern going somehow inside of the vessel. So this is another very new recent indication for elasto in pancreatic lesions. In this setting, we can also use contrast enhancement, and all of the data support that if you have an hypovascular pattern, this is very, very accurate to state the diagnosis of a pancreatic cancer. But these patterns also help to try to classify, to optimize the classification. And as I commented before, pancreatic cancer, hypovascular, neuroendocrine tumors, hyper, metastasis, it depends on the type of cells. I mean, if you see an adenocarcinoma, it's usually going to be hypovascular. But if you see something that is not an adenocarcinoma, it's probably going to be an hypervascular lesion. So again, in METS, you need to have the background of the patient to try to optimize the understanding of the findings on this advanced imaging. And now we have new data with quantification, and with quantification, we can even increase our diagnostic capabilities. So for sure, I think contrast and elasto are very useful in solid pancreatic lesions. But if we combine, we even increase the capability. And this is a study that we published in the journal 217. And we can see that when we combine both, we increase by a lot our accuracy to differentiate benign from malignant. And this is a study published by the multicenter group on Europe on the use of these modalities. And if you can go to the last part of the slide here, combining both, look, sensitivity close to 100% and specificity goes over 80%. So you have two techniques that placed together are very useful to try to orientate the diagnosis of the patient that we are dealing with. But it is not only solid pancreatic tumors, it's also in cystic. In this case, we more and more oftenly use contrast enhancement because the pattern can really orientate a little bit on the type of lesion, but probably the most important part of contrast enhancement in AUS is its usefulness to differentiate between mucin plaques and real nodules when we are evaluating IPMN or mucinous adenoma, and also very useful to characterize the cystic wall, highlighting the possibility of being a worrisome feature. So constant enhancement is very good in cystic pancreatic lesions to try to really be sure that we are really seeing in B mode a worrisome feature that has been already documented. But it's not only tumors. We've also been working a lot in chronic pancreatitis, and we know, and this is a case of normal pancreas, case of early chronic pancreatitis, and we have data. There is a very nice correlation between the number of criteria and the strain ratio, very good correlation between the strain ratio and the pancreatic secretion measured by an endoscopic pancreatic function test, but there's also an amazing correlation between elasto and the histological analysis of the specimen from surgical patients. And we've also detected there is a very nice correlation between the strain ratio and the probability of the patient to have an exocrine pancreatic insufficiency, and that means an advanced chronic pancreatitis. So please, this is a very simple technique, takes 1 to 2 minutes, and is very useful even in diffuse standard patients with chronic pancreatitis. Not to differentiate the type of mass, but just to state the diagnosis and the stage of the disease. But not everything is pancreas. There's a lot of data on lymph nodes, and we know that this method, and you see here an example of a benign node and the comparison to a malignant one. You have here the data in the literature, very high sensitivity, very nice specificity. So for the staging, you see a blue lymph node, that for sure is going to be a malignant one. So if you have the need to target for FMB or FNA, you can use very nicely elasto to try to decrease the number of nodes that you need to target when you, mainly when, for instance, when you're staging a lung cancer. And here in Santiago, for instance, we usually do these techniques combined with our pulmonologist. And believe me, it's a very, very nice technique to try to evaluate lymph nodes in all kind of indications. There is not so many data on contrast enhancement in lymph nodes, but this is a very nice study performed in Japan with Sonathoid, which is not the standard contrast enhancement agent that we have in Europe, that we mainly have Sonoview. But look, there's a specific pattern for malignant lymph nodes that use an heterogeneous uptake, as you can see in this slide. And most importantly, there were no single benign lymph node presented with this heterogeneous pattern. So probably you have any doubt before going to an FNA and FMB, you might think on using contrast as an add tool with an add value in this type of indication. We recently also more and more in subepithelial lesions, we have some data that we can differentiate according to the curve of uptake, or even just for the characteristics of the uptake of the pattern to differentiate between GIST tumors and leiomyomas. And we have also some data that GIST are usually more blue because the P67, I mean, the proliferation is higher, more density of cells, so they tend to be higher. But on the other hand, benign leiomyomas tend to be just as a green pattern, like in a soft lesion. So it's also nice to use in subepithelial lesions, both contrast enhancement, and you can also have the add value of elasto, but there's not so many data on subepithelial lesions. We were thinking just in a minute before, we have Professor Bhatia speaking about the indications of AUS and the role of FMB. And there is this is probably the first study trying to compare FibroScan with AUS-guided elastography, and the results are very promising. This is non-invasive. I mean, AUS is a little bit invasive, just as a gastroscope, but probably in some patients, you can try to use elastography with the aim to establish whether the patient has a liver fibrosis or not. And probably this can be one of the fields of shear wave elastography that we still need to learn much more about this new modality of elastography. But of course, at the end, you have a scope, you have an indication, you have a patient, and you can use these techniques almost in any indication. And just this is some crazy cases that I've used in Santiago. This one here is some notes in a carcinomatosal, in a peritoneal carcinomatosis, confirming that this was really malignant nodes. This suprarenal gland, so we can really differentiate metastasis from normal nodules. This is to stage gastric cancer as well as we stage pancreatic cancer. And we can also direct FNA and FMB with elastography. So take-home messages coming to the end. I'm out of time, and I know we need to go to the live cases with Sandeep. I think advanced diagnostic techniques are useful in many different indications. In fact, we cannot mainly use them in any single case because it's elasto is just press the button. So once you buy the system, you have it for all cases. But probably key point is learning to use and learning to interpret what you see with these both techniques. And nothing more. I would love to welcome you to Santiago to do cases with me of these advanced techniques. Invite you all of you for the next EUS that is going to be 5th of March. And again, thanks so much for letting me be with all of you. And thanks for such a fantastic AUS meeting and pushing forward for increase the use of AUS worldwide. Thank you.
Thank you, Dr. J.
Hello.
Hello.
We want questions because we are already running late and we want to see the live cases. Thank you, Dr. Ignatius. Thank you very much.
Thank you, Dr. Julio. Just to be on the time, it is better that we can ask your question on the email.